Hello, everyone. Welcome back to the De-Escalation Lab. Tim Victorella here with you. I hope you are doing well and staying healthy out there. Things are slowly starting to get back to normal, but we're still kind of in the middle of this thing. And I really hope things aren't opening up too fast. I hope that, this no mask mandate that is now out and about isn't going to cause further problems. So really hope the CDC, the government's doing everything they can and really thinking about stuff because it's still pretty scary out there. But again, I hope you are all well. We're here to talk about de-escalation, mental health, and something really important, near and dear to my heart, and very important for your everyday interactions with clients, patients, whatever you may call them, and that's trauma-informed care. So we're going to get into this today and see where it takes us. Trauma-informed care is really important. It's kind of our foundations of how we talk to someone, how we can interact, how we build those really important relationships, and how we make sure that going forward, someone is treated with the utmost respect, kindness, and ultimately very much taken care of when they're with us and when they're not with us in a facility. So we're going to talk about the 6 guiding principles to trauma-informed care. We're going to break them up a little bit and really dive into this today. So the 6 guiding principles, according to the Center of Preparedness and Responder, is safety, trustworthiness, transparency, making sure there's peer support involved, collaboration and mutual work that's going on together during the situation, having and ensuring that patients, clients are having a voice and feeling empowered, and that there's cultural gender issues that are talked about, discussed, and make sure we're fluid with them, respecting the client or patient's views. So let's talk a little bit more about those foundational steps to trauma-informed care. We want to promote awareness of trauma and develop an understanding. So what does that mean? Recognizing that trauma exists and plays a role in everyone's life. We come to the table with trauma. Our clients and patients are going to come to the table with trauma. We have to understand and promote awareness that that trauma exists and that it's real. We need to recognize trauma-related symptoms and behaviors, appreciating that client's perception of the problem. So you may have had a situation where you're talking to a client and you're sitting there and you're like, yeah, right, yeah, that's really going on. Well, we need to get rid of that kind of belief because we need to recognize that trauma is trauma for that person. What I perceive as trauma, what you perceive as trauma is going to be different, and it's okay. There's no right or wrong. We need to appreciate that to help move to a good solution to the problem. View trauma in the context of a person's environment. Trauma can't be viewed very narrow. Trauma needs to be viewed with a wide lens and really diving into that person's environment. Where have they come from? Where are they living now? How are things around them affecting their trauma, both past and current, and possibly future? Work to lower the risk of traumatization. This is super important. Re-examining treatment strategies and policies. How do we ensure we do not re-traumatize the people that we are working with and trying to help? This can be a very common thing that happens in many facilities and our everyday work, especially crisis situations. We need to understand that trauma exists, and we need to work really hard to make sure we don't re-traumatize the situations. We need to look at our strategies. We need to look at what we're doing every day in our personal practice as well as our organization. What do our policies say? Hopefully, if you work in an organization, there's policies that actually talk about trauma-informed care. When I go out and I do trainings across this country, one of the big things we talk about is where's the policy on trauma-informed care? If there isn't one, let's create one, let's implement it, let's do trainings, let's get people all on the same page so we're all acting the same way towards the clients and patients that we're trying to serve. Creating a safe environment, establishing sense of physical and emotional safety. Now, people might come to me and say, well, wait a minute, we're in the ER and someone needs medications, someone might be delusional in a psychosis situation, very violent, or maybe very suicidal. We need to protect them. So if we're going to go into the room, hold them down, and give them medications or seclude them, are we protecting their physical and emotional safety? So we might traumatize them, okay? but we're looking at the overall safety. If we don't think the situation can be safe in its current state, we have an obligation and duty to keep that physical and emotional safety as best we can. But we ultimately have to keep them safe. We might have to go in there and do things, but we should always try to talk through things, develop steps. Many times in the emergency department, I would go in if the team was thinking about going in and injecting someone with antipsychotic type of medication. We would go in there together and we would really try to make that the last resort, or ultimately that's our goal. But how do we get them on board for our thinking of that? So that's going in there, sitting, talking, going in there a few times if the first few times doesn't work, ultimately keeping in mind that safety is our ultimate goal. So if we need to go in there and do that, we might be creating some trauma, re-traumatizing the situation, but we're trying to keep them safe and alive, or other people safe and alive. And that's really important. But there are some steps that you can do there to really take your time, really make sure we're making the right decisions as a team. We need to ID trauma recovery as part of the treatment plan. If someone's experienced trauma or they're bringing that forward in their life, that this is the situation, right? How do we work that into our treatment plan to ensure that we've validated the trauma, we understand it, and we're developing some steps that people can move towards their treatment goals with trauma in mind? Really important piece there. Supportive choice, the person's control, their autonomy, right? Help clients gain the sense of control and empowerment. So at all costs, the patient client should be guiding their treatment. We are there to help facilitate it. In a crisis trauma situation, one of the best things you can do is step back, take a breath, and have them help guide the thinking. Remember, they're the experts in their life. We need to tap into them. Work to create a collaborative relationship. Together, we got this, right? Can you imagine how empowering it is if you go in and you're talking to a client or a patient and you're collaborative with them? Hey, what brings you in today? What do you think is most important for your care? What are your goals? How do you think you can get to those goals? And you might have the person that's like, well, I don't know. And that's why you're there, to help facilitate that. But you're working hand in hand together to figure out that goal. Conducting routine trauma screening. How empowering is that? IDing past traumas to help clients cope and move through to their recovery. So maybe not every session, right? But maybe every week, every other week, you just check in. You conduct trauma screening, right? And that can include, how are you doing? How is your trauma? Are you activated? Have you had any symptoms? Have you been waking up? Have you been having flashbacks? How are relationships going? Right? We can easily screen for these things, and that's very important. In a crisis situation, I want to know, as the responding clinician in a crisis, if someone's had trauma in their life. It's okay to ask these questions. It's okay to try to understand. That opens up collaboration, helps them with some choice, and then you are able to help figure out the best plan with them going forward. Trauma should be viewed through social cultural lenses. Understanding clients' experiences and backgrounds is key to understanding trauma. Where have they come from? What have they done? Where are they now? What was their family life like? What did they experience? Maybe they came from a culture or religion that was really, really difficult to manage in the sense of the trauma they were experiencing. So we need to understand that. Using strength-based perspective. We should be doing this with everyone we talk to, no matter what, but it is a tenet of trauma-informed care. Help clients foster their strength and find empowerment. Strength-based perspective is just being there in the moment with someone, bringing in the person's strength, not putting them down, not telling them what they're going to do, really creating that collaborative empowerment moment for people that we're trying to help and serve. Work to foster trauma resistance skills, okay? Help normalize symptoms of trauma stress. Try to connect the dots to current and past problems. So we don't want to sit there and be like, your trauma is causing everything in your life, and that's why you feel the way you feel. Let's take a pill, right? We want to be able to say, yeah, it sounds like you've gone through a lot of stuff in your life. There seems to be a lot of things impacting your current stressors. when we're talking, you're showing me a lot of things. You're talking about a lot of things that have happened in the past that have really created a lot of concerns for you, a lot of fears, a lot of trauma. And just having that conversation, right? Trying to connect those dots. All this stuff has happened over here. This is the stuff you're experiencing. What's going on to see the difference? And it's very empowering if you sit there and do that and try to normalize. Hey, it's okay. It's okay that you're feeling this. It's okay that you're experiencing this. And I hear what you're telling me. Now let's get some really awesome coping strategies to get this going and work towards a better scenario for you. Developing strategies, right? This is the next one, to address secondary trauma, promote self-care and skills, ultimately providing hope. Recovery from trauma is possible. It may take a very long time. It's not something that happens overnight. There may be many things in a person's life that activate this trauma. And there could be reactivations of trauma over and over and over again. And that's okay because we've addressed it, we understand it, we've seen the symptoms, we've talked about the symptoms. Many times I hear people that I talk to, I've been diagnosed with PTSD, depression, anxiety, borderline personality disorder. The list goes on and on and on. Schizophrenia. I'm bipolar and I'm schizophrenic. So they've been told they are actually schizophrenic and bipolar. Well, that could be schizoaffective disorder, which essentially is what that diagnosis is. So a lot of people get these labels, which is stigmatizing, because if you go on WebMD, for instance, and you type in schizophrenia or PTSD or trauma, right, there's going to be a lot of things that come up, and then people start WebMDing themselves. So if you're going to give, if you're a professional listening to this, if you're going to give a diagnosis, even in a crisis scenario, crisis center, on the streets, emergency department, talk to the person about it. In an emergency environment, we do a lot of unspecified diagnoses, unspecified anxiety, unspecified depression, unspecified schizophrenic type scenarios, bipolar. The list goes on and on and on of what that is. There could be unspecified trauma-related different disorders. We might not know, just meeting someone for 20 minutes, a half hour, what happens, but we have to have a working diagnosis. And it's okay. This is going back to that previous slide. Collaboration, talking about it, talking about the symptoms. Hey, you know, all these symptoms you're describing could be this. You know, it sounds like you've had a lot of anxiety and a lot of trauma in your life, and maybe you haven't gotten the help or support that you need. So kind of a working diagnosis for us might be this, this, or this. We're not sure 100%, but we need to make sure you get connected a little bit more, work with someone ongoing to really do more assessment and evaluation to figure that out. But I got you, and we're going to make sure that actually happens. So here's kind of the next steps. How empowering is that versus, yeah, we're going to put you on a psych hold, or we're going to give you this medication for anxiety because you're not feeling that great. Right? We need to talk about what we're labeling people with, because this is going to go in the chart. This goes to insurance companies. This follows them. There's a computer system called Epic, and it's phenomenal. And a lot of major hospitals and nonprofits across the country use this. So what Epic essentially is a modality to keep documentation, mental health documentation, a form of that. And if I'm on the East Coast and they're using Epic, and I'm on a business trip on the West Coast and I go to hospital, they're using Epic, the providers can go in and they can see past notes, past history. They can see past diagnoses, current problem lists. So we really need to be mindful of how we're labeling people. And it's okay. We need to give a diagnosis. That's part of our job. But it's okay to explain what we're doing. It's okay to provide a sheet to them. Hey, this is what I diagnosed you with today. Let's talk about it a little bit. Here's some of the symptoms that you're telling me. Based on what you're telling me, this is what it could be. Here's some of the criteria. And here's some of the treatment modalities. And let's get you further connected to see if this really is what it is. Maybe I don't know. Hey, I don't know. So I'm going to say it's unspecified depressive disorder. So that means it could be some kind of depressive disorder or something else. But we need to make sure we get you ongoing care, and you're working with someone to really figure out what this is to make sure we're doing things in the right way for you. That's how you keep trauma-informed care. Open communication, collaboration, talking about symptoms, talking about a treatment plan. I hear so many times when I talk to people that I go, Well, what's your safety plan? Oh, I don't know. It's something that we do every 6 months and it's on their computer. I don't even get a copy of it. So in the next video, we're going to talk about a safety plan that I've developed that I think could be very impactful. It's called the Crisis Rebound Plan. We'll get there. But if you're going to do a safety plan with someone, even if it's a very simple safety plan to keep them safe, give them a copy, print it out, have them write it out, make sure they have a buy-in on it. If you're doing a treatment plan, print out that treatment plan, give them a copy. They should be signing their treatment plans, actually, so they know, hey, this is what we're working on. So be open, be honest. We don't have to be, we could be these amazing clinical people, but we need to step back and go, okay, we can have all this great clinical skills, documentation, all these wonderful things to do for diagnosis, but what at the end of the day is most important is communication, collaboration, sense of trust, trust building, keeping a safe space, okay? And the reason we really talk about safe space in regards to crisis is there's many times, as we've said, crisis can go down differently. Sometimes there's situations where you have to make the situation safe, putting someone on a hold, having police put someone on hold and take them into the ambulance. You're taking someone's rights away. But we can still do this to foster empowerment and trauma informed. The number one thing we should be doing at an exhausting level is trying to help someone get to the hospital voluntarily versus involuntarily without a hold. Sometimes we need to put people on hold. It's the reality of our business. However, 9 times out of 10, I can talk to someone and say, hey, I really think you need to go inpatient for a little bit. I use the analogy taking your car in for an oil change. We all have to do that every few thousand miles. Same thing for us, our medical and mental health. So how I phrase it is, hey, let's get you into the hospital. You're going to meet with some doctors. You're going to get your fluids changed. You're going to get spark plugs fixed out, top the fluids, get you back out there, rotate the tires, and then you're good to go. And so think of a story like that. Think of a way you can express what's going on, because that's really what it is. And sometimes it works, sometimes it doesn't. Being able to be like, okay, well, if you don't want to do that, I'm concerned. Here's why I'm concerned. Here's what's A, B, C, D. List them out to someone. Let the person know why you're taking those rights away. That can still be a trauma-informed lens of practice, okay? That's really important. Common experiences and responses to trauma. So there's the emotional dysregulation. They might feel really numb. There might be some physical stresses, okay? So focusing on bodily symptoms as a way to express emotional distress, hyperarousal, sleep, big one, triggers, right? Something could set off memories of that trauma. Working with veterans, that's a very common thing. They get triggered, or there's a loud noise or someone yelling. They might even hear fireworks, gunshots. They might get into just a verbal altercation with someone, and that can, bam, put them right back into boots on the ground in Iraq, Afghanistan, wherever they may have been. Flashbacks, also another thing. So moving past the veterans, right? Someone that was physically or sexually abused, someone that experienced a mass shooting, first responders that have gone through and seen horrific type situations, medical doctors, social workers, you name it. We've all experienced a lot of stress and a lot of trauma in our life, and trauma-informed care says that we all have, and we don't minimize what we've experienced. The person next to me was in Iraq. They've experienced a lot. It doesn't mean I haven't either, and that's an important distinction to make. So they could experience flashbacks, trauma-induced hallucinations and delusions. So when we're evaluating someone for psychosis, delusional thinking, don't always go to, oh, this person's schizophrenic. Okay, they could be, but let's look at our symptoms, right? Follow the DSM. What does it say? What is the criteria? There's differential diagnoses. If you've ever watched the show House or The Resident on TV, they talk a lot, well, what's the differential? That's the doctor saying, well, this is what I think it is, but it could be A, B, C, D, E, F, G. And it's important for us to mark those off. We can do that in mental health. We should be doing that in mental health. So trauma-induced hallucinations and delusions is something that's truly a medical emergency. We need to make sure we're evaluating for that. Cognition, okay? What's their cognition like? Disruption of core beliefs, perception of self and others, disassociation, are they distancing themselves? Foreshadowed futures. Their behavior, are they reenacting self-destruction or any self-harm, substance abuse, alcohol use? Are they just completely avoiding situations? Are they avoiding work, avoiding family, avoiding being around people? Really important to understand that as well. We can make a difference, and trauma-informed care is the start of that. The more we practice it, the more we understand it, the better we will be. We should make trauma-informed care a daily practice. Trauma-informed care should be something we evaluate and educate ourselves on. Every month, I go over the trauma-informed care tenets to make sure I'm practicing them appropriately. There's a lot of different websites. I list some references coming up. Feel free to check them out as well. There's videos on YouTube about trauma-informed care like mine. There's a lot of things out there. The more we practice it, the better it is. But ultimately, we need to make these policies, trauma-informed care policies. When I ran a 16-bed acute stabilization unit, I activated trauma-informed care on the unit. Staff were required to go in, and staff had trainings. They had to read up on it. They had to have supervision on it and work to practice it. We did scenario-based things where we talked about it, simulations. It was needed. Trauma-informed care can take an environment that's really bad and raise it to an amazing level, and not just lowering safety, right? Violence on the unit, the way the clients or patients are reacting to care and or staff. Trauma-informed care, the research shows it actually will help staff feel more comfortable going to work. There is we're in this together, as in patients, clients, and staff versus a silo that might be there, and really just opens up the door for conversation. And that's what trauma-informed care does every day. So if you have not started practicing trauma-informed care, try to implement some of these practices. Print out these slides. Go on and find trauma-informed care. Take the 6 principles and just start one at a time. Take one, start using it for a few weeks, a month, and then add another one. And just see how your practice changes. If you're in supervision, talk about it. If you're in school, bring it forward for classroom discussions. Hey, I saw this video on trauma-informed care. Why aren't we talking about it? Hey, these are the principles. I think they could be really beneficial. Trauma-informed care could be a sense of love, compassion, kindness, and give you guiding principles to truly make change, collaborate, create safety, and create people working together to come up with amazing solutions. Trauma-informed treatment objectives and strategies. Okay, so we're going to talk about them a little bit more here to make sure we understand. We want to create safety, prevent trauma, re-traumatization, teach and provide psychoeducation. We talked about that, right? We're going to diagnose, we're going to talk about it. Your symptoms, hey, this is what I'm seeing clinically. Talk to the person, okay? Offer peer support. So the ASU, okay, this is what I did when I worked on the unit, is I offered peer support. We started a peer support program. It's really important. Peer support's getting a lot of go ahead, which is really exciting. All peer support really is someone that's gone through a situation, drug, alcohol, mental health, trauma, right? And they're trained. They get trained to just be there, to provide support, to talk about things. A lot of the times, if we had clients on the unit that just didn't want to take medications, it was really impactful for the peer support person to go over and be like, hey, come on, let's go for a walk or let's go talk. And they would just be like, you know, I experienced these symptoms. I wasn't feeling that great. I started taking meds. I felt a little better. I started going to groups. I started doing this, that. It's just a nice way to level the playing field. And a lot of folks will come back and be like, all right, you know what? I'll try some meds. So if you don't have peer support set up, try to set it up. There's a lot of national programs now as well. Normalizing of trauma symptoms. IDing and managing trauma-related triggers when able. Very, very important, okay? So some of the references that I used, SAMHSA has an amazing trauma-informed care website, and there's infograph, which I got for the 6 guiding principles, that visual. The CDC has a lot of information out there as well. So give this a shot. If you're not already doing it, implement it. If you're implemented it already, hone in on it, fine tune it. Go over each one, see where you're practicing. Maybe you're doing really good with the first 3 principles, but you need a little bit more work on the other 3. That's okay. Maybe you are practicing trauma-informed care perfectly, but your organization isn't. So maybe that's bringing it up to leadership, okay? I'm always here to help too, okay? So don't forget to subscribe, hit that like button, okay? So you get notifications when we do videos. We do them as often as we can. But I'm here to help too, TimothyVictorella.com. Reach out if your organization needs trainings. I do them in person and virtually, whatever you need. And of course, all these videos are here as well. So if you have any questions, comments, you want to talk a little bit more, you want to collaborate with me, please reach out. Always here to help. I hope this was impactful and powerful for you, and I wish you all the best on your journey. You take good care.